بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. My topic today is about bilateral renal cyst, common causes, less common causes and rare causes, and the clues to differential diagnosis of the common and less common and rare causes. Key differential diagnosis issues. Imaging features of renal cyst consider the number, size, location of renal cyst to narrow differential diagnosis. And also we look for the kidney size, also may help in narrowing the differential diagnosis. Ancillary imaging findings, example, presence of renal tumor, presence of cyst or tumor in other organs. Clinical factors, example, presence or degree and type of renal dysfunction, and use medication such as lithium. The differential diagnosis of bilateral renal cyst. The common causes: simple renal cysts, uremic cystic disease, acquired cystic kidney disease, autosomal dominant polycystic renal disease, von Hippel-Lindau disease, tuberous sclerosis. Clues for differential diagnosis: simple renal cyst, imaging feature of renal cyst often multiple and variable in size, usually less numerous than in congenital cystic syndrome, and usually of water attenuation. Hyperdense cysts are not uncommon and usually coexist with simple cysts. It is located in cortex, renal sinus, and parapelvic or peripelvic cyst. Kidney size usually normal size and function. Here, this is simple renal cyst in the right and left kidney. On this ultrasound, longitudinal ultrasound shows an echoic cyst here, cortical in cortex, and on the left side it is parapelvic renal cyst. Here, this is simple renal cyst involving both kidneys. On this axial non-contrast CT scan with a preservation of the normal cortex and function in 86 years old man. Uremic cystic disease or acquired cystic kidney disease. More than 3 cysts per kidney in patient with end-stage renal disease, and no history of hereditary cystic disease. This is the clue for differential diagnosis. For the diagnosis, imaging feature of renal cyst. There are usually multiple, located in both cortex and medulla, and variable in size up to several centimeters. Kidney size, usually small and atrophic cyst, and kidneys may become larger. Advanced cases of acquired cystic disease may indistinguishable from autosomal dominant polycystic disease of the kidneys. An auxiliary imaging feature, prone to spontaneous bleeding, into cyst or perirenal space, and there is increased renal cell carcinoma. Enhancing mass in end-stage renal disease means renal cell carcinoma until proved otherwise. Patient presented clinically almost on dialysis dependent and cyst will persist even if the patient receives renal transplant. Here, this is a patient with the uremic cystic disease, acquired cystic kidney disease on axial non-contrast CT scan. We see small kidneys and with innumerable multiple small cysts in both kidneys. And also there is an thickening of the gastric wall due to gastritis induced by immunosuppressive drug in patients who had renal transplant following years of dialysis therapy. Here, another patient, uremic cystic disease, axial contrast enhanced CT scan shows brightly enhancing solid mass in patient with end-stage renal disease, and this is renal cell carcinoma until proved otherwise. And the kidney is small, and we see multiple small cysts in the kidney involving the cortex and the medulla. Here, another patient with uremic cystic disease, acquired cystic kidney, coronal T2 weighted images MRI shows multiple renal cysts in this patient with end-stage renal disease, and acquired renal disease shows also the kidneys are atrophic with multiple renal cysts. Autosomal dominant polycystic renal disease imaging features include multiple and variable size renal cysts. Number and the size of the cyst increase over the time, and the attenuation of the cyst on CT scan and signal intensity of MRI is variable. Hyperdense cyst content and calcified wall due to prior hemorrhage may be seen in the CT scan. Kidney size increase renal size, and there is a progressive increase in the volume of the cyst and kidney. An auxiliary imaging features cyst and in other organs like in liver, pancreas, seminal vesicles, and it is associated with intracranial arterial aneurysms, aneurysm. Clinical factors: there is family history and a progressive loss of renal function. 50% evolved to end-stage renal disease by 6 decades. And gene mutation, BHD1 and BKD2. BKD2 gene mutation associated with milder later representation and fewer renal cysts. Here, this is coronal T2 MRI weighted images with multiple renal cysts in this patient, autosomal dominant polycystic disease, and shows enlarged kidney, and also renal, also liver cysts. Here, this patient with autosomal Polycystic renal disease, non-contrast enhanced. There is enlargement of both kidneys with multiple variable size cysts, and some of cysts have hemorrhage here, as in this is more cyst, and this one, and represent as a hyperdense cyst. Here another patient with autosomal dominant renal disease and multiple renal cysts, some of them with hemorrhage, as we see on this one, and this one, and that one, and we see also multiple liver cysts of variable in size. Here, another patient with autosomal dominant polycystic renal disease with multiple small cysts in both kidney, mainly cortex, and 62 years old man with preserved renal function. And this is presumed type 2 adult polycystic renal disease. Von Hippel-Lindau disease, imaging feature of renal cyst, multiple and variable in size renal cyst. About 60% of patients have renal cyst. An auxiliary imaging feature, renal cell carcinoma, represent in about 25 to 45% of patient histology. It is a clear cell carcinoma and bilateral in 75%. Pancreas can be involved, and cyst, serous microcystic adenoma, and neuroendocrine tumors. Adrenal gland, it is also involved with often with pheochromocytoma, and it is often multiple. CNS, it is involved also with especially the cerebellum and the brainstem and the spinal cord with hemangioblastomas. Patient has multi-system disorder, and it is autosomal disease. Here we see patient with von Hippel-Lindau disease with multiple renal cyst and solid enhancing mass on the left kidney, and this is renal cell carcinoma. Here, this patient with von Hippel-Lindau disease, axial CT scan shows multiple renal cysts here, there, and multiple also pancreatic cysts. Some mass here, it is enhancing renal cell carcinoma, and this is classic for von Hippel-Lindau disease. Tuberous sclerosis, imaging features of renal cyst, multiple and various in size. An auxiliary imaging feature kidney, you have hamartoma and angioimylomas, often multiple and bilateral. Solid mass without obvious fat in patient with tuberous sclerosis is still most likely to be angiomyolipoma, not renal cell carcinoma or other tumor. Hamartomatous tumor in the brain, lung, heart, skin also associated. Clinical factor, multi-system disorder, and it is autosomal dominant disease. Here, this patient with tuberous sclerosis, axial contrast enhanced CT scan shows mass lesion of fat density. Here on the left side, it is angiomyolipoma, and here could be cyst, could be fat. Here, another patient with tuberous sclerosis, axial contrast enhanced CT scan, multiple masses involving both kidneys or fat densities with the spontaneous hemorrhage on the right side. Sometimes due to partial volume artifact or averaging, it is difficult to differentiate the small angiomyolipoma from simple cyst, which is usually present in patients with tuberous sclerosis. Less common diagnosis: lithium nephropathy and medullary cystic disease. Lithium nephropathy imaging feature: we have multiple bilateral microcysts about 1 to 2 millimeter and located in the cortex and medulla, and the kidney is normal to small in size. Clinical factors occur in patients who take lithium for a long time for by and causes diabetes insipidus and renal insufficiency. Patients are rarely dialysis dependent, unlike present with acquired cystic disease of uremia. Here we see contrast-enhanced CT scan with lithium nephropathy, and we see multiple small cysts about 1 to 2 millimeter involving both kidneys in normal sized kidney. Here, this is lithium nephropathy. Axial T2 weighted images shows multiple small tiny cysts throughout the cortex and medulla in both kidneys in patient with 69 years old, a woman receiving long-term lithium for bipolar disorder. The kidney are diminished in size and function. Medullary cystic disease imaging feature of renal cysts are small size, about 0.1 to 1.5 centimeter renal medulla and corticomedullary junction. The cysts are located. Kidney size, small to normal size kidney. Patient has nephrophthisis or salt-wasting nephropathy, progressive renal failure, and anemia in young patient. Here, this patient with contrast-enhanced CT scan, medullary cystic disease, multiple renal cysts involving both cortex and medulla with progressive renal failure and anemia and salt-wasting nephropathy, typical atypical imaging and the clinical feature of medullary cystic renal disease. Rare but important causes: glomerulocystic disease of the kidney. It is the cysts are small in size and usually in the renal cortex, and it is arises from the proximal convoluted tubules and Bowman space. Patient clinically sporadic of familial occurrence and rare condition associated with renal insufficiency, but rarely end-stage renal disease occur, affect children and young adults. Here, this is a patient with axial contrast enhanced CT scan with multiple cysts involving both kidneys, and he is on dialysis with hematuria with infiltrated mass renal cell carcinoma with the tumor extended to the IVC, renal vein and IVC. Alternative differential approach: multicystic renal disease associated with tumors, uremic cystic disease, renal cell carcinoma, especially papillary type, von Hippel-Lindau disease, renal cell carcinoma, and the tumor of pancreas and adrenal, pheochromocytoma, and CNS hemangioblastoma, tuberous sclerosis, angiomyolipoma, and rarely renal cell carcinoma. Thank you for listening. Hoping to see you soon in another talk.